Hello, I'm Dr. Michael Cookson, and I've been asked to give a urology perspective on the expanding world of germline testing for prostate cancer. I currently am the professor and chair at the Department of Urology at the University of Oklahoma and work at the Stevenson Cancer Center in Oklahoma City. The views expressed here are my own and not representative of any specific organization such as the AUA or SUO. All of us are aware of an increasing public awareness of genetic testing in popular press. Patients are increasingly familiar with the idea of genetic testing. There's direct-to-consumer products that are rapidly evolving. Patients will likely seek medical advice from providers such as urologists as well as oncologists with respect to the role of genetic testing in many phases of their treatment or diagnosis, and urologists need to assist patients in obtaining the correct information so they can make informed decision in this regard. This slide shows a multitude, but certainly not a complete list, of some available genetic testing that is direct to the general public or can be ordered by the physician. And so we can see here that there are lots of choices to choose from. Some of them are panels that can be ordered that are specific for prostate cancer, and even single tests can be obtained in instances. Many of these companies have billing and assistance available for the patients to provide them with more information before they do the testing, so they'll know the cost that will be associated with a panel or an individual test. There was a Genetic Information Non-Discriminatory Act in 2008, and it's important for physicians and providers to be aware of this. This is an act that prohibits genetic discrimination in health insurance. It also prohibits genetic discrimination in employment. But the law does not protect against discrimination in regular life, disability, or long-term care insurance. And an employer with fewer than 15 employees may not be responsible for this either. So there are some things that are protected and some things that are not. And while this transcends the limits of my talk today, it's important for patients who embark on this journey for genetic testing to know that there are some protections as well as some non-protections as they go forward. Why consider germline testing? Well, first of all, it can be used as a risk assessment tool. What is the probability of a disease? It can be used potentially for prevention if the disease has a modifiable risk factor. It can be used prognostic. So does germline alteration have an impact on the prognosis? What about treatment selection? Are certain treatments more or less effective in the setting of specific genetic alterations? And what about the familial risk in testing? Is there a need to invite other members of the family for testing based on individuals' results? More importantly, I've been asked to address what about guidelines and what guidelines exist. Interestingly, the NCCN Hereditary Breast and Ovarian Cancer Syndrome guidelines were probably the first place where guidelines and some mention of recommendation for prostate cancer screening for BRCA2 carriers were mentioned. But of course, most urologists are not using hereditary breast and ovarian cancer syndrome guidelines. And so some of this information was really a little below the radar. In 2017, the NCCN did publish some specific guidelines noted for prostate cancer, noted to be associated with BRCA2, 1 and 2, in a family history, and that is clearly noted on this slide, where it was becoming more conventional in prostate cancer early detection guidelines to look for risk of these type of genetic alterations. Flash forward to 2019, now there is definitely guidance on obtaining certain genetic testing in men with family history of high-risk germline mutations. So unlike prostate cancer history, which most urologists were used to obtaining, we're now taught to look for other familial type syndromes that can be associated with a higher risk of genetic alterations. And these include breast cancer, pancreatic cancer, colon cancer, ovarian cancer. And so you see some of these recommendations not only for the BRCA, but also mutations such as in the Lynch syndrome. There's also not only a family history of prostate and the other familial things that I mentioned, also it's recommended to do genetic testing in the presence of intraductal carcinoma when it's found on a biopsy. So those are some specific instances where genetic testing might be recommended on initial diagnosis of prostate cancer. This slide goes a little further, and I won't read all the individual criteria off the NCCN guidelines, but I think that it raises the awareness that we're really talking about more than just prostate cancer when we look to the family history. And so digging a little deeper into some of their ancestry, perhaps looking at whether or not there is other of these familial syndromes, such as the colorectal, breast cancer, pancreatic cancer, even some of the urothelial, looking further than just, hey, is there anybody else in your family that has prostate cancer? These are some NCCN guidelines that recommend clearly germline testing is recommended for all men who present with high risk, very high risk, regional, or metastatic prostate cancer. So very specific, high risk individuals, they're recommended to undergo germline genetic testing. In addition, genetic counseling resources and support is critical in the pre-test counseling and is preferable when possible. And then once the test has been obtained, post-test genetic counseling is also recommended if mutations are identified. The JCO published one of the first consensus papers, which was a consensus conference conducted in Philadelphia in 2017. This was a multidisciplinary conference that included medical oncologists, radiation oncologists, genetic counselors, health policy, epidemiology, a variety of patient stakeholders, as well as representatives from some of the various guidelines. As you can see, NCCN was included. And they published these very nice recommendations which reinforce what was previously mentioned. Important in the consideration for obtaining genetic testing is a shared decision-making encouraged, where patients understand that there is some risk associated with the knowledge of this genetic information, that familial syndromes above and beyond just prostate, such as was previously mentioned, are included. Men with metastatic CRPC were recommended to undergo genetic testing, and a variety of genes were recommended in this paper, and you can see those listed here. These included the BRCA1 and 2, the HOXB13, as well as DNA mismatch repair genes. So when you look at this, you can see that it's the beginning of recommending not just genetic testing for men with metastatic castrate-resistant prostate cancer, but then it goes a little further to suggest some of the individual genes that could be tested for, because, again, the beginning infancy of this is that not only are the tests obtained, but then if we can link some of these genetic mutations to druggable targets, that's where there is even added value. Currently, the SUO, the Society for Urologic Oncology, made a position statement in 2018 supporting the use of genetic testing in men with prostate cancer, as noted in the NCCN criteria, and also endorses the need for appropriate genetic counseling for men with prostate cancer before and after these genetic tests are obtained, to allow them for proper information to be passed on, not only for the families, but also to their other relatives. I think it's important that we recognize that when men undergo this genetic counseling, sometimes the genetic tests are positive for certain genetic variants. There can be variants of unknown significance. Again, that's where some of the counseling can come in, not only to explain to these men, we don't know the true value of these genetic alterations, but that more information may come forward in the next year or two, and they may be recontacted or may want to reach back out to their provider to see if any of these alterations that were of unknown significance now have significance. So when I summarize this in terms of just the big picture for genetic testing for prostate cancer, it's a rapidly evolving and it's clinically available. Consideration for genetic counseling and screening in men with family history of prostate cancer and other genetic syndromes associated with prostate cancer, as we mentioned, breast, colon, pancreatic, ovarian. Discuss genetic testing for all men with newly diagnosed high risk, very high risk, advanced, metastatic, and castrate-resistant disease. Adoption will be facilitated by the dissemination of these much-needed consensus statements, such as being developed at the second consensus conference in Philadelphia, the development of guidelines, including NCCN, but also perhaps AUA, as well as the European guidelines, as well as development of educational initiatives to inform practitioners on not only what tools are available, but when and in what clinical scenarios those would be obtained. And the Society of Urologic Oncology does have a position statement recommending urologists increase their understanding of the role of genetic testing and develop collaborations with these cancer genetic specialists and genetic counselors for the optimal care of their patients. I hope this has been importantly informative for you all to raise awareness of the role of genetic testing, and it is an evolving role in men with suspected or men with newly diagnosed high-risk disease, as well as those with metastatic or castration resistance. Thank you for your attention.